Okay, I think I got everybody set up. We're going to talk about assistive and orthotic devices tonight. One of the ones we're going to start off with is wheelchairs. And then we're going to end with the foot and ankle, the AFOs. You have a fair amount on there. Might have a little bit on knee. I doubt you'd have anything on hip. You will have canes, crutches, and walkers. Looks like we got 8 of you. Okay. The NPTE takes a biomechanical approach to these devices and use it for disabilities that they'll specify in the question. The PT exam is likely to have questions more about what is the most appropriate orthotic device for this person. Just like prosthetics that we'll talk about on Friday. The PTA is going to be more on fitting and training. But fitting and training could show up in PT questions as well, so be ready for it. Fitting is a real problem quite often. The goal of an assistive device is to provide them with a device that allows safe ambulation. With the least amount of restriction. So you got to sort of think of the surface they're going to use the device over. If it's level, that's one thing, but if it's not level, you have to make certain adaptations, or maybe other devices may be better. We're trying to make walking safer, trying to decrease the risk of falls. Trunk stability, trunk balance are major things that you should always test. And they make a difference as to what type of device you might give somebody. And really, any patient that's not bedridden and over about 2 years of age should have a way to ambulate. That means sometimes giving a wheelchair to a 2-year-old. And there are wheelchairs specifically designed for young children that actually can grow with them a fair amount. With wheelchairs, you have manual and you have electric. In electric, there's 2 types. There's electric wheelchair, which you can do a whole bunch of adaptations to, including seating systems. And there's a scooter, which are really not adaptable. You really can't make changes to them. Scooters were originally designed with somebody with like MS in mind, who has pretty good upper extremity function, pretty good trunk balance, is not a problem with them, but their lower extremities just don't have it for the endurance. Scooters are more designed to provide that endurance for somebody. The wheels and casters are important in wheelchairs. The seating system, the type of armrest you use. A standard armrest is not detachable, so oftentimes we need a detachable armrest. A desk height is lower in front. If somebody really needs to get a good push off from it, a standard armrest would be better. And the wheelchair rims we can do differently because we can do projections, either horizontal or vertical. We can make a friction rim, which somebody like C4T1, they don't have great grip. That improves the grip. Somebody with RA may do better with a friction rim, or the hands are really involved. And it doesn't stress the hands as much. So the wheelchair components, we think about the backrest is one, the seat, and the backrest and the seating systems are usually part of the thing you try to design together. Then you have the drive wheels. The small wheels are called the casters, and those wheels have rims. You have different types of leg rests. One type that, if I had it on the exam, is an elevating leg rest. I would most likely not pick that, because an elevating leg rest is going to cause your patient to sacral sit, so regardless of what type. Once you elevate the legs, they'll slip out and start going into sacral sitting fairly easily. It really promotes that. It also prevents the blocking of the extensor synergy as much. If you got somebody with edema in a leg, an elevating leg rest is probably not the way to correct that. Using a compression sock on or something like that might be much better. The push handles and the axle, and we can move that axle forward and backwards. Most of the time it's moved backwards, particularly with amputees. And I'm not talking transtibial, I'm talking transfemoral. If you're unilateral, it probably needs to be back about 4 inches. If your patient has bilateral transfemoral amputations, it needs to be back close to 6 inches because that lengthens the wheelbase and puts their center of gravity more between the base of support. They don't have a lot of weight out in front, so you need to move the axle back. You don't want to move it too far back, because if you move it too far back, it increases the wheelbase of the wheelchair quite significantly, which means it doesn't turn very well. It needs a lot more room to turn, which is going to limit the patient and restrict them from getting into some tighter spaces. Let's see what my next slide is. The caster is a front wheel. It can come in different sizes and different diameters. The type of tire doesn't make a heck of a lot of difference out there, although a pneumatic tire is lighter. And lighter weight wheelchair, when a patient's propelling it, or even somebody's pushing it, it's easier. And particularly over anything but really hard surfaces like a tile floor. So most community chairs have pneumatic tires on them, both the front and the back. A real small front caster, I've seen them 1.5 to 2 inches in diameter. That allows that chair to turn really quickly. They're usually solid too. A chair for wheelchair basketball, you need to be able to turn quickly. that's an advantage there. Wheelchair tennis would have a very small front caster. And they're going over a very flat surface. The problem with the small caster, if you go over regular surfaces, it can drop into a hole or something, act like a pivot point, and tip the chair over. I had one gentleman on a farm that I was seeing as a home health visit, and he needed some way to get out to the barn from his house. Very irregular surface, typical of a farm with some gopher holes and stuff like that. We ended up doing about a 10-inch front caster on his wheelchair. So he did not tip it over. The bad thing is you can't corner it very well. You can't corner it as easily. It takes more effort to corner the thing. But not tipping over was the primary goal of that. Leg rests, as I went to, do not think about an elevating leg rest unless absolutely necessary. The only one patient I might put an elevating leg rest in is an acute transtibial amputee that hasn't gotten their prosthetic yet, and they're not wearing that prosthetic all day long. You want to keep the residual limb from swelling up. Elevation there might be one of the better ways to do it. You also keep the knee from being flexed all the time, and a knee flexion contracture is one of the big things with the transtibial. So that type of patient, maybe. And it would be a short-term adaptation. And sometimes an elevating leg rest, and then I actually put a lot of my transtibials in like a straight knee brace originally, because I don't want that knee to start flexing too much. And it's hanging down all the time, it'll start to develop a flexion contracture. No matter how much range of motion I do with them, they'll still develop one because it's sitting there all the time. And they're sitting in that chair until they get their prosthetic. So you may want to sort of avoid. That's one case I might want to give one. The drive wheels are the big ones in back. There is something called a one-arm drive chair. And a one-arm drive chair, there's two rims on one side. They're used for somebody that doesn't have function in one of their upper extremities. So if their left upper extremity is disabled, like with hemiplegia, they really don't have function in it, they need to have that rim on the right side. So the inside rim controls the left wheel. The outside rim controls the right wheel. And if they grab both rims and push them forward, then they'll roll straight. If they take the outside rim and pull it backwards and push the inside rim forwards, that'll cause them to turn to the right. They may ask you that. Sometimes it's easier just with that inside rim to pretend like it's on the left side, and what would somebody normally do with the left hand? They're going to do the same thing with the inside rim. And it's a way not to screw it up as you're answering the exam question. Seating systems. As I said, you need to assess somebody's trunk If they don't have a lot of trunk control, you need to recline the backrest about 30 degrees and put in lateral supports. That gives them that substitutes for that lack of trunk control. If I do that, I open that hip joint up more than 90 degrees. There's something called a tilt in space where the back is locked to the seat. So if I recline the back, the seat comes up and maintains that 90 degrees. Or you can actually set them less than 90 degrees. A C5 is a good example of a patient that needs to use that type of back rest. The seat itself, you can put cushions on. An air-channeled cushion, good example is a Rojo. They're sitting on these pillars of air, and just movement of moving an arm, moving their head from side to side, will change the pressure in those pillars somewhat and actually reposition the patient. Patients on those usually do not have to be repositioned. And it's good for a C5 on up. The patient does not have to be repositioned with them if they cannot reposition themselves easily, or it's too cumbersome to reposition. Sitting on a flat surface, somebody who's paralyzed, they should be repositioned about every 15 minutes. That is really impractical. You don't want to take 60 seconds or up to 2 minutes to try to unweight one side and then unweight the other side to reposition to give yourself a weight relief. Stopping what you're doing every 15 minutes is pretty unreasonable to ask somebody to do. Repositioning somebody every 2 hours is fairly realistic. The bad thing about an air channel cushion is you sink into it, the patient sinks into it, so if they try to slide off of it, the seat will come with them, and that'll bunch up and cause a fall. So air channel cushions are really only used on are really appropriately used on patients that are totally dependent in transfers. And a C5 most of the time is. They really don't have much to help themselves. I've never seen a C5 transfer independently by a typical technique we would consider safe. There is something called a swivel bar, but that they need to have such strength that they can lift their whole body with one arm. Just by flexing one arm, they can lift their whole body weight. Very few people can do that. Like doing a one-arm pull-up. If you're really trained like mad and you're really young, you might be able to do it. But very few patients ever get to that point that they could possibly do something like that. And then if they could for a while, could they maintain it or not is the next question. Probably not. Not for a significant period of time. Unless they kept constantly training. The other type of cushion we might want to think about is a gel cushion. A gel cushion distributes the weight over a larger surface area, thus increasing your time. That usually will buy most patients up to about 2 hours. really, you sort of want a break after 2 hours of doing something. So repositioning every 2 hours is something reasonable to ask the patient to do. It's reasonable to ask caregivers to do. And that's a nursing standard of repositioning their patients every 2 hours. So a gel cushion buys most patients into that range. There is one type of gel cushion called the J that has really a waxy packets in there that distributes weight from the ischial tuberosities in a larger surface area. They're a fairly firm seat, which allows easy transfers off and on, allows better posture usually as well, and they're not very heavy. A true gel is quite heavy, but the J and the gel buy you about the same amount of time. Gel cushions are a lot cheaper. If I buy a case of them, I can probably get them down to about $45, $50 each. For facilities, like if you're working in a nursing home or something like that, suggesting them buy some gel cushions to decrease their amount of decubiti and things like that might be a great idea. The rims on the wheels, I can have horizontal projections, but if I have horizontal projections, it makes that chair really wide. Now, a C5 or a C6 that cannot push, they need the horizontal projections because they really can't push the rim at all. They can just pull. And they sort of windmill their arms and pull, and that's what propels the wheelchair if they have horizontal projections. But you're making the chair, the projections are 6 inches, so 6 inches on each side, that's a foot there, plus you need a little bit of room to clear, about 2 more inches on each side. That makes that chair so wide it won't fit through most doorways. The patient can propel the chair in a controlled manner through most doorways. Now, in medical facilities, they can't, because most of the doorways are so wide, are wide enough to push a bed through. Those type of doorways, yes, they can get in and out. When I worked at spinal cord and head injury rehab, we put our C5s in manual chairs. And we wanted them to get the exercise. And we also wanted to make sure they had the responsibility to get to PT on time, to get to OT on time, to get to their meals on time, things like that. Also gave them more of a sense of independence, which is important too psychologically with these patients. They also got a heck of a lot of endorphin rush from actually trying to do it, and actually really helped get their arms in shape too. So it had multiple benefits to them, particularly during the rehab process. We never sent C5s home with manual chairs, because you went in the house, they couldn't get in the bathroom, they couldn't get most places they needed to get. Even hallways in homes may be too narrow. Most modern houses, probably the hallways are wide enough, but an older house, no. Hallways tend to be more narrow, so the doorways. So manual chairs good in facilities, and that's about it. But a C5 can propel a manual chair. C4 can't. For the PTs in the crowd, or sometimes even the PTAs are doing this anymore too. Trunk stability, their spasticity, like tilt in space would not be necessary in the acute hospital because they haven't developed spasticity yet significantly. Usually that takes about 3 months after a spinal cord injury to develop. And they haven't developed it enough yet. They may need the reclining back for orthostatic hypotension. Then I could get away with just a reclining back on a chair, which is a lot less expensive than tilt in space. In the rehab, they're going to start to need that tilt in space because if I didn't put a tilt in space on them and had a reclining back, their extensor tone would kick in and they basically slide right out of the chair onto the floor gradually. Also a reason why you don't want to have a seat belt on a patient because there are patients that basically hung themselves by sliding out of a chair. The seat belt catches around their neck and they've hung themselves. The type of transfer makes a difference. If they're doing a stand pivot, you could use a standard armrest, which is higher in front so they can push off of it better. It wouldn't need to be removable. But if they're going to the side like a sliding board or a squat pivot transfer, then you need to be able to remove that armrest completely and get it out of the way. If they want to go to a table or something, if they have a standard armrest, they would be sitting back from the table. To really get to a normal seating position at the table, they'd probably need a desk arm, which is lower in front and higher in back. Desk arms are what we see in most wheelchairs. Well, some patients that really need that upper extremity push off, like some of your spinal cords, we're going to talk about somebody walking with KFOs. They would need to have a standard armrest. They wouldn't necessarily need removable. Patient's ability to control the device. A C3, they can swallow, they can blow, and they can suck in. That allows them to use a device called sip and puff. And sip and puff, you can use that method to do a lot of things, particularly if you're hooked up to a controller that's really like a laptop, and you can actually have drop-down menu items and things like that. They can use the sip and puff like a mouse and be able to click on things that they want to do. You can do environmental controls like shut the lights off, turn the lights on, turn the TV off, turn the TV on, change the TV channels. You can do a whole bunch of things with that sip and puff. And your very high quads need that. You also have to have somebody with pretty good intelligence to be able to use that. Somebody with TBI or something like that probably couldn't figure out how to use something along that lines. Moderate to severe brain damage. A joystick is probably the best way to control. That's the best control over a manual or over an electric wheelchair. An electric wheelchair, I can do all these seating systems I just talked about and things like that, all the cushions and things like that. You cannot do that with a scooter. And when the exam's talking about a scooter, they're really talking about the old Amigo, which the steering is like a bicycle mechanism, redesigned for somebody using both hands. It is portable easily. It breaks down into really the drive wheels and the motor is one component. The seat is another component, and it's usually like a captain's chair. And the steering mechanism is the third component. The idea is you break the components down, throw it in the trunk of your car, drive where you want to go, lift it out of the trunk of your car, assemble it, and then go tooling off in your scooter. Redesigned for that MS patient that has strength but does not have endurance. That's really what a scooter is for. You cannot do any adaptations to it. Electric wheelchairs, you can do tons of adaptation. You do tilt and space. You can do the different types of controllers like sip and puff. Joystick is probably the best controller to use. It's sort of the most natural to use too for patients. If they don't have good grip, you can still do what are called goalposts. And they put their hand in there and it sort of grabs their hand a little bit, and then they use it like a joystick. That's the most accurate way for them to drive the chair. Sip and puff, you can get it going forward and backward, but it's really hard to get it to turn exactly where you want to turn. Turns are very difficult in there, and there's a fairly good learning curve to that in most patients. The joystick is much easier skill to acquire. You also got to think about the surfaces that they're going to drive the thing over. Are they flat, level surfaces? Do they have to go up and down ramps? ADA requires ramps. And so 1 to 12 is the ADA minimum. So for every 1 foot up, that ramp needs to be 12 inches long. And after every 30 feet, they have to have a rest area, which has to be about 5 feet long. So they can go up, park for a little bit, catch their breath, then tackle the next uphill. Does that got wheelchairs down pretty good for everybody?
Yeah. Do we need to know like the measurements?
Usually it is about 2.5 or 2 3/4 inches from the greater trochanters to the side gives you the width of the chair. Again, about 2 3/4 inches, 2.5 inches between the front of the popliteal space and the front of the wheelchair. And that gives you the chair size. In practical terms, you really have to look at the sizes the manufacturer makes and try to fit into one of those. You don't want something too tight, but you don't want something extremely wide either. Because the wider the chair, the more restricted they are. And in other words, the doorways have to be wider and things like that for them to get through it. It also makes it not corner as well. It should be about 2.5 inches from the back of the chair to the scapula if they have a regular height wheelchair. Now, there's sport chairs that really only have like a 3 or 4 inch back on them. That allows the patient to lean back. If they have good abdominal muscles, they can really propel that chair really well. And they can get it going really fast. A good example is marathons, where the wheelchairs actually do a marathon much faster than the world-class runner does, because they can really get that thing moving. But they use their abdominal muscles along with their arms to do that. And if you have a very low back, you can lean back and lean forward, and that gets your abdominals going. Sometimes a high back is required. If they have a high back and they're lean back on a thing, they have to have a headrest. Because the sternocleidomastoideus muscle is not meant to hold the head up all the time. Really, the SCM is more to balance the head, but not lift the head constantly. So if they're reclined back, they do need to have a headrest on it. Gait patterns. The 2-point gait is the most natural and it's the most efficient. And it's a contralateral pattern where they step with the left foot and put the right cane forward at the same time. And then they go to right foot and left cane. And it's most like a normal arm swing. The cane's really doing the arm swing as well. That's the most efficient. Even using a wheeled walker with 2 front casters on it, that gives you that 2-point gait pattern. They just keep moving. Anytime you start and stop, you lose efficiency because you burn energy to stop the movement and you burn more energy to accelerate the movement again. So if it's more of a continuous movement, it's more efficient. A 4-point gait pattern is probably the most stable, and somebody with spinal ataxia needs to do this because they're moving the cane, then they're moving the foot, then they're moving the cane, the other cane, then they're moving the other foot or crutch or whatever. They're only moving one thing at a time so they can use visual correction to do that. And that makes it the most stable. But when you move something, you move it and stop the movement. Then you accelerate the movement and then stop the movement. So it's the least efficient of any of the gait patterns. A 3-point gait pattern is used for partial or non-weight bearing on one side. There's a swing to and a swing through. The swing to pattern is more stable, but again, you're stopping and starting the movement, which makes it less efficient. A swing through is a continuous pattern as we're walking, so it is more efficient. They will have a question that has to do with gait pattern. I definitely can expect that, and it could be any of these. Crutches and canes. Axillary crutch stabilizes the trunk, but it's got one point of support. This is what we use if somebody needs a lot of stability. Stabilizing that trunk really helps a lot. This is probably the most stable, except it's got only one point of support. Forearm crutch, also called a lost strand or Canadian crutch, not nearly as stable because it really doesn't stabilize the trunk at all. You need a lot more arm strength with it. It doesn't put pressure on the brachial plexus, which that axillary pad can, particularly if they're leaning forward or not using it properly. This one has less problems there. I don't know of a patient that actually had brachial plexus damage. They maybe get a zinger going through or something like that, but as soon as they stop walking, it goes away usually. But they could put some intermittent compression on the neurovascular bundle in the brachial plexus with this type of crutch, but adds a lot more stability. Being one point of support allows you to go over fairly irregular surfaces. It also goes up and down stairs really easily, and you can still use the crutch on the stairs. If they have a railing, I like them to use a railing instead of the assisted device, at least on one side. Maybe use a crutch on the other side. But the rail's more stable because a better point of support and better balance. So less chance of falls. A straight cane provides probably the least amount of support. Got to have a fairly strong arm to be able to use that. If I gave them one cane, I would put it in the uninvolved side. I don't know how many patients I've seen coming from a doctor's office where they gave them a cane and the patient they have a right knee problem, they're using it in their right hand. A quad cane has a wide base of support to it. Usually we see the small base quad canes. If you turn it sideways, it'll get up and down stairs, but you got to turn it sideways, which means that the grip isn't really in a great position. Made more for patients who are walking over level surfaces. And a lot of people have come back to me with the use of a hemi-cane. A hemi-cane is extremely wide. It should be kept to the side. It basically has legs that come out from it. It's almost like turning a walker sideways, but keeping it to the outside. It's almost that big. it makes it very difficult to get through a doorway and things like that with it. It's good walking over level surfaces. But when you're using a lot of these devices, if I'm using a cane on one side, my base of support is coming between, like if I use a cane in the right hand, my base of support is going towards the right leg, away from the left leg, and towards that cane. So your center of gravity is moving. We want to keep it between the 2 feet, if at all possible, because that's naturally where it's best. The use of, like the quad cane, the hemi cane, probably not the greatest idea in the world. My stroke patients, if I have a choice, I go parallel bars first. I try to hold their involved arm on the parallel bars, so they're getting support through it. Maybe have to straighten the elbow out for them, and then I'll go to like a wheeled walker with just a wheels replacing the 2 front pegs. So I have 2 casters on that, replacing the 2 front pegs. And that keeps their center of gravity between their 2 legs, which is the most natural. And as they improve, that's probably going to actually be the least chance of them falling again as well. So in the long run, I'm probably decreasing their risk of falling. Going to a quad cane right away, that center of gravity is going way towards their uninvolved side. It's going to make them neglect their involved side even more. They're not getting the weight bearing to the arm, which really helps that involved shoulder and the involved upper extremity as well. Overall, your outcome probably isn't going to be as good. But they may be independent sooner. Walkers, generally they have 4 pegs. And we pick it up, put it down, pick it up, put it down as we're walking. That's the standard walker. Most walkers we see are folding walkers just because of storage issues. You can fold it and store it pretty conveniently in a smaller space. A non-folding walker is lighter because that folding mechanism weighs quite a bit. And you do a swing to or swing through. A 2-wheeled walker still gives them good lateral stability, but they lose some anterior posterior stability when they're using a 2-wheeled walker because it can just fly out in front of them a little bit. So you have to make sure you're balanced on your patient. Usually it's a lateral balance, which is more of a problem than anterior posterior. So the 2-wheeled walker works quite a bit on quite a few patients. The 4-wheeled walker, and most of the walkers are swivel casters, so the thing really can move any direction, which means they're really not getting any support in any one direction either. They're getting support straight down, but they're not really getting that stability with it. So I really wonder why we're actually using those. Because we're losing really the stability, and that's the main reason for giving somebody a walker. Foot orthotics is a posting is one of the things you'll see on the exam. A post is a wedge. It's thicker on one side, narrower to the center. It controls a lot of the subtalar joint motion of inversion, eversion a lot. You can also put it in the forefoot to control supination and pronation. And you can post them both in the forefoot and in the hindfoot, like underneath the calcaneus. That causes difference. Their arch supports, they really prevent the arch from falling. Posting, though, can raise that arch up as well. There's a scaphoid pad that pushes up on the navicular bone, and that would cause a supination of the forefoot and inversion of the hindfoot. And we can do heel lifts. And sometimes if somebody has a lot of calcaneal Achilles tendonitis, a heel lift would really take the pressure off of that. For women, sometimes having them wear their high heels might be a way to do that, because that's really a heel lift too. And those are done inside the shoe. Inside the shoe, you can go up about 1/4 of an inch lift at most. Some books say only 1/8 of an inch. I think you can get, most books say you can get away with 1/4. And I sort of feel the same thing too. If they have an extra depth shoe, which really look awful, they're the orthotic shoes or orthopedic shoes. They're deeper, you can get away with more of a support in there. Outside the shoe, I can do even higher. If they need a lot of change, high heels, a Thomas heel. Thomas heel is really thicker on the medial side of the shoe. The whole sole is thicker, including the heel. That tends to cause supination of the forefoot and inversion in the hindfoot. Metatarsal bar is a thick piece, usually about 1/2 inch or so, that's put right behind the metatarsal heads, so they toe off the bar before their weight goes over the toes. It also keeps the toes from bending. Somebody's had a bunionectomy or has had hammer toes surgically corrected. They need that metatarsal bar for a fairly lengthy period of time so they don't bend those toes. If you have a huge leg length discrepancy, a shoe lift is a good idea. I remember one patient that went in for well, she had arthritis in her hips. She went in for an elective total hip replacement. Well, the doctor missed the leg length because how far you pound in the prosthetic gives you your leg length. He missed it by about 1.5 inches, which is fairly significant as far as gait goes. Normally about 1/4 of an inch is pretty normal, or 1/8 of an inch is pretty normal leg length discrepancy. That's enough to really affect the gait, really cause arthritis in the knee, low back problems, things like that. So went and put a shoe lift on her to try to equalize the leg length on both sides. The doctor's feeling was, well, you're going to have both hips done. When I do the second one, I'll just equalize it out. if they have a big shoe lift, you need to rocker it. That means sort of beveling it. So when they hit a heel, if you rocker the heel, when they go from heel strike to foot flat, they roll into it, and you can control that roll better. If it was 90 degrees, you'd actually fall into foot flat, probably with a good foot slap. Again, with the toe, if you rocker the toe, you can roll off of it. You don't have to lift your knee up as high. Most running shoes have a rockered toe on them. That makes it easier to run. You're not having to lift your knee up as far, which means you're not expending as much energy, which means your endurance should be better. But when you have a big shoe lift in, you got to rocker it. Or they got to really lift that whole foot way up in the air by lifting their knee up. To figure out what's going on at the foot with orthotics, you really have to understand some of the biomechanics of the foot. Probably the first thing I look at when I try to analyze somebody is what's their longitudinal arch like. Is it a low arch or a high arch? Low arch or pes planus, they're in loose pack position in the tarsal bones. So whatever goes on the hind foot really doesn't affect the forefoot. Or something going on in the forefoot really doesn't affect the hind foot. If they're in pes cavus, they're in closed pack, so whatever happens here affects here. They're tied together. The hind foot's important because that changes the angle going up the leg and affects the whole kinetic chain. That affects a lot at the knee, at the hip, even the SI, the low back, all the way up to the head. There's something that shows up in the exam sometimes called an anterior heel spur, and that's where the plantar fascia is actually pulling out of the calcaneus, right on the bottom of the foot. Take your thumb and push in here, and your patient would come off the table usually, if they have a heel spur there. You can also see it on x-ray quite often because it's a microavulsion fracture happening. That means they had a really tight plantar fascia when they have that heel spur. I don't want to put something, I can put something here, like a post, but I wouldn't want to use like a scaphoid pad that pushes right at the end of where that the osteophytes from the heel spur are, because that would put a lot of pressure on. The patient just would not tolerate that. Even maybe an arch support they would not tolerate very well. I can get away with posting because I'm really not pushing on the plantar fascia directly. Now, plantar fascia has a lot of problems with it because it's a ligament, but it's also the tendon of the flexor brevis muscles because they originate from there. And those are fairly significant muscles. And they attach at the IP joint. Posterior heel spurs are back here in the Achilles tendon where it inserts in the calcaneus. If they're having a lot of problems there, maybe a heel lift is the best solution for that. There's two arches in the foot. There's also, besides the longitudinal arch, which is really what I look at first, there's also a metatarsal arch. Out here, it's really the biggest between the first and second, or the second and third toes is the apex of that arch. If it falls down too much, the metatarsal heads are pushing right on the digital nerves, and they get what's called a Morton's toe or Morton's neuroma as a result of that. Now, pronation collapses the metatarsal arch. It also collapses the longitudinal arch as well. Just remember, pronation causes most of the problems. That's the reason why stabilizing shoes correct somebody who overpronates. They just do it to different models do it to different degrees. What's going on up the leg, you see probably best at the knee. If the knee's in valgus or varus, it's pretty easy to see. There's also another joint at the ankle called the talocrural. As far as you're thinking for the exam, just think about this as where dorsiflexion and plantar flexion occur. The subtalar down here is where an inversion, eversion occurs. They may, in an exam question, give you a valgus or a varus down there as well, because the Talpes in the pediatric literature talks about Talpes that way as calcaneal varus or calcaneal valgus. But they're talking about inversion, eversion as well. The foot gets really confusing because you have different authors coming with different perspectives to it, and they use different terminology. We also have podiatrists writing a lot of the biomechanical stuff as well. They use different terminology as well. But you got to think about coming up the whole leg and what's going to happen throughout the leg. If you've got varus at one joint, you've got valgus, you have a compensatory valgus at the next, then you have varus at the next, working your way up the kinetic chain. And we analyze the kinetic chain from the floor on up, particularly the subtalar joint upwards, because the whole weight comes down on top of that subtalar joint. University of California, Berkeley lab brace, the UCBL, something I used in children. I would want, ideally, a child to start using this brace as soon as they start to pull the stand, which is somewhere around 9 months. But as soon as they're pulling the stand up on their own, it's probably a good idea to have them in this. It's used to correct either the varus or valgus deformity of a Talpes. Usually the the equinovarus or equinovalgus, the equino means plantar flexed. Usually that is surgically corrected because they're stuck in full plantar flexion. There's no way in the world you're going to stretch them out of that completely. Sometimes doing a tendon lengthening is the best. Often they develop it just to how they were positioned in the womb. You see more talpes in multiple births, for instance. But they're stuck in there with the foot replantar flex. That's probably what causes it. Surgery doesn't do a great job of correcting the inversion-eversion component, but the UCBL does. It is a heel cup that comes up really high. It comes up right underneath the malleoli, so it really grabs the talus, and you post it. And you post it to correct either the inversion or eversion to try to crank them back to normal. Usually about every 2 weeks you're adding a few degrees to it, maybe 2 to 3 degrees to change the angle. And that's trying to straighten the leg out. So every time the child is weight bearing over it, they'll actually cause the tarsal bones to form differently. Because once you grab that subtalar joint, then the forces coming forward across the tarsal bones is going to hit different portions of them. It'll slow development of the bone in one area and increase, not slow in another area, and it actually changes the shape of the tarsal bones. You can use it until they're about 3.5 to 4. As soon as they develop a longitudinal arch, because babies have flat feet to begin with, as soon as they develop the longitudinal arch, which is about 3.5 to 4 years of age, then it won't work anymore, because that means the tarsal bones have really formed. The idea is to change their shape as they're going from cartilage to bone. That's how this bracing works. So by the time they're 4 to 5, they don't have to wear any orthotic device anymore. And you've straightened the foot out. Gotten a normal arch usually. And gotten that subtalar angle changed. It works primarily on the subtalar joint. AFOs will always be on the exam. The first question is metal versus plastic. Metal are more comfortable for the patient to wear because there's a normal shoe and basically a leather-lined calf band. So they're actually really comfortable to wear. They're pretty easy to put on because they're not that much more. It's just one strap you have to do over normally putting your shoes on. So they're fairly easy for most patients to wear. And if they swell up a lot, they can swell above the shoe, and there's a lot of room there. So somebody with right-sided CHF, things like that, where there's swelling when the foot's dependent, this actually may be more comfortable. Plastic, it feels like you have this hard plastic surface in there. Doesn't accommodate swelling very well because it's really a lot more of the lower leg is encased with just some of it being exposed. You sometimes get some skin breakdown more with plastic. Plastic doesn't absorb moisture, so you get maceration issues with it. as well, they are lighter. So someone with a metal, you got to make sure they have strong hip flexors, or they won't have a good step height. If you don't have a good step height, you'll catch your feet on things and trip and fall. Plastic is very lightweight. It's usually not significantly altering the step height the patient would have. Plastic, you can go from shoe to shoe. Metal is built into a shoe. So you're stuck with one pair of shoes and metal. Metal's a little bit bulkier. It's also noisy. If you got springs in it, they squeak. If you got pins in there, they click. So it's not as cosmetic by any means. The plastic is much, much more cosmetic, also much lighter. You can adjust metal a lot. You can make one metal AFO do a lot of different things. Plastic, they're really not adjustable. You got to throw them out, get another one. And the off-the-shelf plastics do not fit all that well. Custom molded plastic does fit well, but we're talking something that's about as costly as a metal AFO. So they make a plastic AFO very much like how they make the socket to a prosthetic. They do a cast, they do a negative, and then they pull the plastic over that negative. They like the metal AFO on the exam because you got two channels and you can adjust them. I can put springs to assist things, and I can put pins to form a stop that limits range of motion. That term stop is used a lot in the exam. You have an anterior and a posterior channels. I can do different things. If they just have foot drop and I want to prevent foot drop, I could put a spring back here. So when they go into dorsiflexion, they'll sort of load it up. And as they lift their foot up, that energy will come back and lift their forefoot for them. If they're getting really spastic, I don't want to have any range of motion, so I want to stop both flexion and extension. I can use two pins. After the spasticity goes down to some extent, I still may want to block plantar flexion but allow dorsiflexion because our foot normally comes in dorsiflexion during gait. I can get away with just taking everything out of the anterior channel and leaving the pin in the posterior channel. And that does the same as a plastic articulated AFO. A spring leaf AFO, the back is really thin, so when they go from heel strike to foot flat, back of the orthotic actually bends and then returns that energy at toe off, lifting the foot up. A solid AFO blocks all motion. And it also gives pretty much a total contact. In that respect, it might be a little bit better for preventing ulcers because it's got the total contact, particularly if it's custom molded. Usually when a patient needs the the spring leaf AFO, like a stroke patient, is usually when they're flaccid, which is the first, which is their initial presentation. They're usually not walking all that far, so an off-the-shelf plastic may be okay, and they're fairly cheap. You're talking maybe $15, $20 for that AFO. You don't mind throwing that away usually. A solid AFO, when they're starting getting spastic, you want them weight bearing a lot. We're usually starting some pretty good gait training with them, and they actually may develop a functional gait when they're very spastic still. That's why a solid AFO is used. It stops the spasticity because you don't want any movement at all. Any movement triggers more spasticity, so you want to stop all foot movement there. The plastic AFOs do not control inversion, eversion as well as the metal. A metal, I can put a T-strap in to prevent somebody inverting or everting, depending on how I attach the T-strap. And that could work actually much better. But the solid AFO is something I'd use during that period of time. They're actually getting fairly functional on it too. Oftentimes, if somebody has a lot of foot deformities, things like that, I may actually go ahead and do a custom molded AFO, even if they only need a spring leaf, because they can walk with that. If they have more of a foot slap, so be it. They will. With the solid AFO, because it doesn't allow them to come into dorsiflexion or any plantar flexion at all, so they will have more of a foot slap from it. Usually at that time they're not walking that much. And I continue with the solid AFO until it comes to a point where they really can control the spasticity. And then I could go to what's called an articulated AFO, where I just cut the ankle, put a silicone elastic joint that allows some dorsiflexion, but then the back of the heel and the back of the orthotic prevent the plantar, when they contact each other, that prevents plantar flexion. It's the same thing as leaving a pin in the posterior channel of the metal AFO. The other AFO question could have to do with the floor reaction or the ground force reaction AFO. The ankle there is solid and it's set at a certain degree, and I can set it in about 5 to 7 degrees of dorsiflexion or 5 to 7 degrees of plantar flexion. If I set it in dorsiflexion, it prevents that knee from going back into recurvatum. It holds it flexed about 5 to 7 degrees, which is normal standing and normal walking posture. If I put it back in 5 to 7 degrees of plantar flexion, I'm actually throwing that knee into recurvatum, which locks it. So somebody who's a really weak quad and they can't, their knee looks very unstable, it's buckling on them. If you put it in plantar flexion, it would help to stabilize that knee to some extent. If they're really weak, it probably wouldn't help. But if they're just slightly weak, it would help. in there. Early on in the stroke, they may have some quad weakness and things like that. In the stroke rehab, you could use a ground force reaction AFO to do that. Later, they'll get in the habit of throwing that knee back in the recurvatum, which is going to tear up the posterior part of the knee capsule, the posterior cruciate, if they're walking good distances. And that's where the ground force reaction AFO in 7 degrees of dorsiflexion is used. Bellarmé, who is one of the authors of a lot of the orthotics and prosthetics, would use that 5 to 7 degrees of dorsiflexion because she'd only give this type of device to somebody who is walking a lot. If they can barely walk at all, she's saying, why aren't you going with a KFO? Because they're only household ambulating, you're not really limiting them. And a KFO is going to control that knee 100 times better than a ground force reaction AFO would. KFOs have different types of knee joints. They're usually fairly manually locking. There are some new ones out which have joints similar to what you'd see in a transfemoral prosthetic, where they've taken some of the mechanics, some of the ideas from that, and put it into the knee joint. And that would be the safety knee, which is only locks in about the last 20 degrees of knee extension, hydraulic knee or pneumatic knee, where you can have extension assists and extension brakes on them. And I've even seen a computerized knee joint as well out there. I don't think you'd have that on the exam. You have a drop lock, which is sort of the standard, where if the uprights become parallel, it drops. A weighted collar drops and locks the knee. To unlock it, you got to lift the collar up. Which, if you got two hands to unlock both the medial and lateral side, fairly easy. If you weigh over 100 pounds, you got to have both the medial and lateral upright. And most of our patients are. You can also have a lever lock, and when the knee is straight, the lever will snap down and lock. It'll snap in a downward position and lock the knee up. To be able to unlock the knee, you need to elevate both levers, but you can connect those levers with what's called a bail, which is a piece that goes in the popliteal space connecting the two. And you just have to lift that bail to unlock both knees. So you could do that one-handed. But the knee is locked. What type of gait pattern would you see if the knee is locked in somebody? They can't bend their knee during a swing. What type of gait pattern would that produce?
Circumduction.
Right. You're going to see a circumducted gait with a KFO, which is not as efficient. And KFOs are more for household ambulation. They're not for community ambulation, because that inefficiency is going to limit somebody's endurance. That's the reason for like the safety knee, the hydraulic knee, and the pneumatic knees, is they can allow that knee to bend during swing and lock up during stance. You also have two straps, and these are the ones you actually tighten up first, the infracondylar strap and the supracondylar straps. There's actually an anterior and posterior component of each. So if I tighten up the anterior ones, I'm going to bring that knee joint forward and loosen up the posterior. If I tighten the posterior and loosen up the anterior, I'll bring that knee joint backwards, which is going to throw that knee into more of a recurvatum. Ideally, it should be about, it should be slightly in front of the center of the knee joint, because our knee normally is flexed about 5 to 7 degrees. But how you do these straps makes a difference. Now, actually, when I have one fabricated, I usually have a plastic piece put in the back, just one strap in the front. That means that knee joint angle is actually set, and the patient just has to tighten one strap up, which makes it easier to put on and take off. If I have two straps, I'll actually sew the posterior ones so they can't really undo them. They just undo the anterior one to take the brace off. And that maintains my setting as well. Because changing that knee, these straps can really affect that knee joint being more anterior, more posterior, which is going to affect their gait pattern by affecting the TKA line. Most reference sources I find, they talk about the TKA line in the sagittal plane. And normally the center of the knee joint should be slightly in front of the TKA line. It's a weighted line that's dropped from the trochanter. It should fall right in front of the talus. And the knee should be slightly flexed, so it's slightly forward. The knee being flexed also allows a more kinesthetic sense as well. So that's why that flexion is fairly important. It can be used in the frontal plane. And if the center of the knee joint is more medial to the TKA line or more lateral to the TKA line, if they're more lateral, it's varus. If it's more medial, it's valgus. The exam has gone as far as talking about it being in the transverse plane. And that's looking at internal external tibial torsion, in-toeing and out-toeing type things. I think that's pushing the TKA line theory a little bit beyond its scope. It's really hard to see. Particularly with spina bifida, the meningocele, where they have a spinal cord injury, usually in the thoracic or lumbar area, we're starting to get them up and walk them with a brace. HKFO or THKAFO can be used depending on how high their lesion is. Oftentimes, if you let the knee joint get, or the hip joint get a little bit lacking in extension, it allows them to lock their knee better. And and you can get away with maybe even a KFO in those patients because the tightness is helping stabilize the hip joint. This type of bracing you can unlock it and sit down, and then if you want to get up and walk, you have to lean forward and throw the knees backwards to lock the knee joint. They really need to push up with their arms to be able to do that, which is usually the hardest thing about using them. Then they walk with a swing through gait. And swing through is fairly efficient. The 3-point swing through. Fairly efficient gait. Usually you can walk limited community level with that. You can at least walk that 200 feet, which gives you the limited community level. Really not much over that, but somewhere in that range, which is functionally what we have to walk a lot. Definitely good household ambulation with that. They're putting these braces on in the morning, taking it off when they go to bed at night. They're wearing it throughout the day. They're walking and standing in these braces throughout the day. So they're getting a lot of good weight bearing through the leg. That actually causes the legs to grow a little bit more from the weight bearing. The bones mineralize better. You don't have as many pathological fractures. That weight bearing also gets the blood vessel development, things like that. They get better blood circulation through it, so the DVT risk is reduced. But it's not a reciprocating gait, which some therapists think is needed for normal brain development. Although there's really no evidence supporting that. No really good, reliable evidence supporting that. I wouldn't say no evidence, because you can find a study to say absolutely anything you want, depending on the method the study was done by. Medically, patients are going to do a lot better with the HKFO because they're using it all the time. These reciprocating gait orthosis is made for reciprocating gait. It's as bulky as the HKFO, but it also has a bar that goes right across the back of your butt. And you lean back, that bar pushes your leg forward. So you unweight, you lean back, you unweight to the other side, lean back, and that leaning back throws the leg forward. That takes a tremendous amount of energy to do that. It's also a 4-point pattern, which is very inefficient energy-wise. It's also a very abnormal pattern, so it takes a long time to learn. I could not start a child learning to walk until they were like 2.5 to 3, because I'd have to have really good communication with them. And actually they would actually have to have fairly good upper body and trunk strength to be able to do this too. Where the HKFO, I can start working at that around 18 months or so, maybe even 16 months. That swinging is not that abnormal of a pattern, and the kids pick it up pretty easily. So you can actually get them walking on an HKFO much before an RGO. You cannot sit in an RGO for any prolonged period of time. They could sit 5-10 minutes to rest, but then they'd have to get up again because it would end up causing skin breakdown if they sat there too long. And kids with spina bifida are at risk of skin breakdown and increased risk, so that's probably not a great thing to do. So they really cannot sit in these braces for prolonged periods of time. And that's when RGO really about, basically, they're used in therapy only. A kid comes to therapy, you put the brace on, you walk them a little bit, start about 2.5 or so years of age. They maybe walk for 10 to 15 minutes per therapy session, maybe once or twice a week, maybe once a month. They're really not getting any standing, any weight bearing for prolonged periods of time with this. They're not using it for any prolonged periods of time either, so you don't get great leg development and things like that with them. They have a tendency to be a little short because they're living their life out of the wheelchair. They're not walking functionally. This is a functional brace. This develops the legs. The kids are walking with their peers. That has a big social development instead of being in a wheelchair all the time. I think developmentally the HKFO is a little bit better too. There's evidence supporting, there's very strong evidence supporting that. This does cause a very abnormal but reciprocating pattern. Cervical orthotics. One is a soft collar. A soft collar supports their cervical muscles. Gives them a chance to rest a little bit. They don't have to do as much work holding the head up all the time. Somebody who has strains of muscles, like from a whiplash, it would actually allow the cervical muscles to heal better. They will atrophy, though, too. So you don't want to keep this on a long time, but usually the muscles heal within about 4 to 6 weeks and you can start removing it. And that's before you begin getting significant atrophy. You probably should wean somebody off of this. I usually tell a patient to take their collar off. When your head starts to feel heavy, put it back on for 1 hour. Give your muscles a break. Then take it off again. And usually by the end of a day or two, they're no longer having to put their cervical collar on. And they've weaned themselves off of it. Taking it off all at once, I have patients, sometimes they'll go see their orthopedic surgeon. He'll just take the collar off, throw it in the trash. You don't need that anymore. And they come back in the next day with their muscles all in spasm. They need to wean off the thing. It doesn't limit range of motion, though. A hard collar does. They could be called a Philadelphia, a bivalve collar, is sometimes another name for one. It really blocks cervical flexion. They can extend, they can rotate inside of it, they can laterally bend as well, but it stops flexion. If you think somebody broke their neck or possibly broke their neck, this is the first thing that's put on, because flexion causes the bony fragments to go right into the cord and the nerve roots. So you want to block flexion more than any motion at all. That's why it comes on first and really is taken off after the x-rays come back absolutely clean. There's no problem. If there is a neck fracture, the most common brace is a 4-poster halo. Have any of you worked with a patient wearing a halo?
No.
No.
That thing weighs particularly the halo itself weighs about 20 to 30 pounds. The whole brace weighs about 45 pounds, way away from your center of gravity. It makes that head so heavy. If they stood up normally we lean forward when we stand up. If they did that, they'd end up kissing the floor because that weight's so heavy will just pull them forward onto the floor. They actually have to keep their shoulders back over their pelvis when they stand up. To do that, you need really strong quads and really strong glutes. So if you got somebody wearing a 4-poster halo, you really want to start some quad glute strengthening to allow them to transfer, to allow them to get to standing. It does stabilize all directions. There are 4 pins that are just screwed down to the skull, and they're screwed tight. If they start feeling pain on one of the pins, most of the time they feel like, well, it's because it's too tight. It's actually because it's too loose. The pin is backed out, or the skull itself, the bone of the skull has eroded away underneath the pin. Now, osteomyelitis can cause that erosion, but you usually see a lot of redness around the pin site and maybe some drainage. You see that inflammation, maybe an increased temp, and usually a little bit of drainage around the pin site if they're infected. If you don't see that, it probably just loosened up and backed out a little bit and needs to be tightened back up. You don't want to move a patient until this is stable, because if that's on them, they do not want the bones of the cervical spine to move at all, because movement slows up healing and maybe can cause a non-union. When you see this on a patient, they do not want to have any cervical motion at all. Maybe just moving the legs in bed, doing some bed exercises, things like that are what you could get away with. You really can't do a lot of rolling with this when a patient has one of these on. They almost have to grab on trapeze and come straight up and then pivot over. They can't roll on their side. Usually this type of bracing will be on about 4 to 6 weeks because the cervical spine heals is really centrally located. It heals relatively quickly. A spinal cord injury would not be appropriate in a rehab wearing a halo, because you really couldn't do a lot with them when they're wearing one. They're also called somies because they really come from the sternum and the hips and the shoulders on up. There is a 2-poster version that does not really block flexion and extension at all. It restricts side bending the most. And maybe even allows some rotation. Somebody with a fractured transverse process, they may stabilize with a 2-poster, although most of the time they'll go to the 4. There's also the Minerva brace, which is popular on the East Coast, or at least it was popular on the East Coast for quite a while, in the New York City area. It's basically made out of carbon fiber. It comes up really high in the back, pretty much grabs the whole occipital bone, and pretty much encloses it, plus a good portion of the parietal area. And it's got a strap that goes across the forehead. That would stop flexion. It'll really stop side bending, but they still can rotate underneath it. You could not tighten that forearm band enough to stop rotation. And we're just lying there, somebody comes in, we want to rotate a little bit. So that's a normal motion that people will have. There's really nothing in your visual field at all, so it doesn't have the claustrophobia issue that a 4-poster halo does with the bar coming down right in your visual fields. It doesn't cause any scarring necessarily, although I've seen patients break down underneath that strap, which creates a horrible scar across the forehead. One that usually needs to be surgically closed. I see most neurosurgeons that I know of would not use a Minerva, because if they want that type of mobilization, they want the 4-poster halo. They don't want them to move at all. This allows a little bit of movement, which slows up the healing time. They would prefer to, if they're getting a little claustrophobic, just sedate the patient instead and keep with the 4-poster halo. The TLSOs primarily prevent flexion. They keep a patient extended. A cash brace, it should be cash, not sash, has a bar going down the front with a sternal pad and a pubic pad, has one strap. It prevents somebody from flexing. It allows rotation, it allows side bending, but they cannot flex in that. Great to prevent somebody from getting a thoracic compression, wedge compression fracture. So patients that would be prone to like the Dowager's hump or things like that, this would actually stop them from getting that fracture. They got to be pretty skinny, but those are the patients, because they have a greater momentum that's really greater. It's hard to get the pubic piece to make contact, so it wouldn't stabilize. But for a skinny little lady that's really prone for osteoporosis, this one strap's easy to put on, easy to take off. It doesn't weigh very much. Good brace. They wear it while they're up. A Jewett, which I don't have listed here, which is unfortunate because it's the most important, is a cage. It's got a sternal piece with bars going underneath the arms. There's an anterior and posterior bar to it. There's a bar in back as well. They come down and join to a pubic piece. This really prevents side bending. It prevents really much rotation in most of the spine, not the upper thoracic spine, but limits most of motion. It's got a corset in the back, so it sort of holds you in extension. It allows more extension, but it won't allow flexion or side bending or much rotation at all. I can also put a lateral strap on over the apex of a scoliotic curve. The higher curve is where you put it over, and then attach it to the other side and pull from that. Pull that strap tight. That takes the curve out of them. And that works pretty well. For lower scoliotic curves, a Jewett brace can be used with a side pad to it. And actually, this is becoming the most common thing. These uprights can usually be unscrewed and lengthened so it can grow with the patient as well. So if you're using it on a child as they're growing, you may want to do it. Every time you put it on, you tighten the lateral strap, so you're increasingly reducing that curve by doing that. And you can use pretty much the same brace during the scoliotic treatment. A Milwaukee brace is a Jewett with a chin piece. The chin piece keeps the upper neck in full extension, and it's fairly uncomfortable. It also has you looking up towards the ceiling all the time. If you want to look forward, you actually have to bend at the waist considerably to look straight ahead. It's used for problems of T6 and above. A scoliotic curve of T6 and above would need a Milwaukee. That's really the only brace that will do that. That's uncomfortable. I would say a child going through school that was looking at the ceiling all the time, I think the grades would end up suffering because they wouldn't be able to pay attention to what's going on in the classroom very easily. Probably not the greatest idea as far as treatment. Surgery is probably much better for them, where they could put in Harrington rods, the line the spine. The newer Harrington rods have clips that don't grab the Harrington rod completely. They can slide up and down it. So the internal hardware sort of grows with the patient. And they actually they put more pressure on the intact side of the vertebral body instead of the wedge side. They take the pressure off that. That allows, with pressure, you slow growth. With reduced pressure, the growth increases more. And basically what happens is it causes a normal spine to grow. You may put this in a 6-year-old. You may put it in a 10-year-old. Later on, after the spine has sort of started growing at the same time, you don't see the wedging of the vertebral bodies anymore. You can go ahead and remove the hardware, and they usually end up with a normal spine with no hardware. They used to put Harrington rods in very late teens, early 20s to align the spine, but then the Harrington rods would have to stay in place. Because they held the spine straight, the spine was no longer growing. So if the Harrington rod broke or one of the clips broke, they would go back in the scoliotic curve again. They'd fall back into it. Getting them earlier, putting the Harrington rods in that allowed them to slide the clips that allow to slide up and down the rods really allows the spine to grow more properly. And then they don't need to keep the hardware in. I'll guarantee you they'll self any metal detector going through it with Harrington rods. Boston overlap is a body jacket. Sometimes it's bivalve, sometimes it's not. You maybe just pry it open, insert the child, let it snap shut. It is more open on one side, is solid on the other side. So the solid side will push the spine towards the opening, and that straightens the spine out. You could do that the same as a Jewett with a pad, but this thing, about every 5 degrees of scoliotic change, they'd need a new jacket. If they grow at all, they'll outgrow these jackets a lot. You're doing a lot of this on growing children. They'll probably have to go through at least 5 or 6 of these for one Jewett. So a lot of insurance companies won't pay for this bracing anymore. It's a solid body jacket. It's very hot to wear. Cold winters would be fine. Hot summer, it'd be a sweat box. Even if you perforate it, you still sweat a lot. You could have skin maceration underneath this. This is just an open cage. Allows air to go in and out. Might be a little bit more cosmetic than the bars because it sort of fits the body more, but it makes the kid look a little bit more overweight. To work, either the Jewett or the Boston brace are meant to be worn except for at therapy where you're stretching them and trying to strengthen them. You'd probably take them out of the jacket to do that. For bathing, they get out of the jacket, but the rest of the time, including sleeping, they need to be in these for them to be effective. I know I had one patient that after 3 weeks of treatment, Johnny's up to 20 minutes. Johnny should be up to 20 hours. If it's going to be effective. A lot of compliance problems with these braces. With scoliosis. The surgery is sort of done at once. There's not the compliance issue anymore. That compliance issue makes the bracing ineffective. LSOs prevent extension. They have strapping or supports in the back that prevent extension. They usually have a corset in front that holds it in place. They do allow flexion, but they prevent the amount of extension. Chairback braces are a good example. Which is like the back of the chair with a corset in the front. It really supports your back from going backwards. Lumbosacral belts they're used by weightlifters a lot. They're thicker in the back. they prevent that hyperextension, which causes like spondylitis, spondylolysis, or spondylolisthesis, things like that. Companies in the early 90s, some of the workmen's compensation insurance companies gave huge discounts to companies where a lot of their employees did lifting if they wore and used these belts all the time. And it's basically an LSO. Some of them had straps that held in place over the shoulders, so when somebody had to lift something, they had to tighten their belt. If they weren't lifting anything, they could just loosen the belt and let it go free. The idea was to cut down on back injury. The insurance companies did away with that within a year. I think Liberty Mutual backed off within 6 months. What happens was, what the study showed was the number of injuries went down. You didn't have, I lifted too much, my back hurt, I can't come into work tomorrow type claims. That's a spondylitis type issue, which usually doesn't have any permanent ramifications, although it can lead to arthritis of the spine down the road. What they did was have a lot more herniated discs that required surgery. So they ended up with a lot more serious back problems. Because if you have this brace that you feel like you can tighten up, I can lift more than I normally could lift because this brace is allowing me to lift more. And they were really they were blowing out discs and things like that more often. So they didn't have as many back injuries, but the back injuries they had were much, much more serious and more costly. So that immediately got done away with. EPO really found the answer to the problem. Is anything that needs to be lifted, there's actually a rating on the labeling that's in the stores. Every product that needs to be that could be possibly lifted is rated. Anything over 50 pounds, the employee has to use a mechanical lift to lift. They cannot lift it manually. That cut their workman's comp back injuries down very significantly. Medical facilities have looked at that and provide more Hoyer lifts. If you have to lift a patient, you need to use a Hoyer lift. You cannot do even a moderate assist transfer. You have to use a lift to do it instead, which for us makes it hard to get a patient able to transfer on their own, but does cut down on CNA back injuries and things like that, because back injuries in CNA is probably the #1 workman's comp injury in CNAs. Usually PTs are exempted from that, but the CNA would have to use a lift to get the patient in and out of bed. If they cannot do it themselves. Did you guys get a little bit out of this webinar tonight?
Yes.
Yeah.
I was questioning whether I could actually even do it because I was coughing so much today. Okay. We all got through it. Friday is prosthetics.
Okay.
And the week we go over some neuro stuff, I'll throw in the spinal cord levels. You do have to know the different spinal cord levels. It does make difference in the type of wheelchair and things like, or the type of assisted device to walk with spinal cord injury. And there will be questions that direction on the exam. And the HKFO versus the RGO. On the actual exam, if I was taking it, if the question is worded, what type of device would you give the patient to assist their development, I know they're after an RGO. Even though there's no really good evidence to support that. If the questions were more about function, I would go more towards the the HKFO or the KFO. And often you can get away with a KFO on a lot of these patients, because they have some spasticity. It might hold the hip in a little bit. They'll lose some extensor range of motion, things like that, so the thing will lock up easier and the hip joints are more stable. And the trunk gets spastic, so it gets sort of stable too. So often you can get away with a KFO on most of these patients. Ideally, that's better, because if you got to do the hip joint, that weighs more. If you got to do the thoracic cage, it weighs more. So the least weight, the best, which will allow better endurance and better function. So I'll see you guys on Friday.
See you then. Okay, bye.
Okay. Bye-bye.
Bye.